I'll give you an example of acupuncture. Just have some water. Of acupuncture. I don't know, perhaps it's not very popular here in Egypt, but in the United Kingdom there is a market for acupuncture, and there is acupuncturists, and every IVF clinic might hire an acupuncturist with a view to improving the pregnancy rate and the live birth rate. Please correct me if I'm wrong. How can sticking needles in this patient's front head will improve embryo quality? It is just beyond the joke. And also the unsubstantiated claim of herbal medicine, medical intervention that will cure every ill, and generally the unsubstantiated and the exaggerated claims that people make about those interventions. And it's important to remember, when the claims are exaggerated, they most of the time are untrue. And it is important to remember that. Even astrology is being involved in IVF. I'm sure I'm speaking to a distinguished audience, but I would be surprised if any of you knew that there is a pregnancy planet. And Jupiter and Venus are thought to be the most closely linked to fertility. You didn't know this, Professor Ramsey, did you? Okay? And the danger of misinformation is also important, because you heard Professor Abunasa saying that probably half information is more dangerous than giving full truths or ignorance, because if you are ignorant, you are blessed with that ignorance, but if you have half the information, you could end up doing harm. And the way success rates are presented is another way also of manipulating the facts. You will find some centers presenting their pregnancy rates with just percentages. You don't know how many patients. I remember we had a next door clinic where they started doing PGD. They put on their website success rate of 66%. And then when we asked, we knew that they did 3 cycles and they had 2 of them having positive pregnancy tests. That's really very informative. The other thing is also when people publicize their pregnancy rate and they say, I have a pregnancy rate of 68%. What kind of a pregnancy? Is it a positive pregnancy test? Is it a clinical pregnancy, or is it an ongoing pregnancy, etc.? I think that some may not appreciate that having a positive pregnancy test is not the end. It may be a good beginning, but unfortunately it's not guaranteed. And some people may not appreciate that at least 1 in 5 of the patients who will have a positive pregnancy test, sadly, will not see a heartbeat on scan, because their pregnancy will be only biochemical. So that's good 20%. And if you wanted to have a guide figure, if your positive pregnancy test is 60%, which is fantastic, you translate this into maximum of a 40% live birth rate, a baby to take home. So it's important to put the full picture. The other epidemic in our field is the notion that the immunology or the immune system has suddenly become so hostile and it is attacking our embryos. I always tell my patients, if the immune system suddenly had some metamorphosis and it is attacking the embryos for the poor IVF patients, so what is happening in the general planet? We wouldn't have 7 or 8 billion and population crisis if the immune system does not know what it's doing. We must subscribe to the intelligent design that the Creator has given us. And those business of natural killer cells, they kill hostile cells. They kill hostile agents, but they don't kill cells of their own. I give an account of an English patient who said on one of the websites, I received frustrated phone call from the clinic. They told me my cytokines were raised. They gave me Humira, which is anti-TNF alpha, should never be used in IVF context. And the patient herself worked out that it doesn't make sense. She doesn't know what she was doing. And then the doctor suggested intralipid and other intervention, as you will see. And this natural killer cell testing is becoming very popular, and it is sad to say that there are some clinics here in Egypt subscribing to natural killer cell and immune suppression therapy. Ashley Moffat is a professor of reproductive immunology, and she is the one who invented natural killer cell name. And she has never regretted anything in her life than calling it natural killer cell. because these cells don't kill anything in vivo. They kill only in vitro. And she has likened the relationship between blood natural killer cells and natural killer cell in the uterus. It is a relationship between the traffic in Tahrir Square and the traffic in the circular road or whatever outer road that you have here. So the relationship is really not there, and they are not representative of each other. And the evidence does not support this, whichever way you look at it, at the RCOG, at the British Fertility Society, at the Human Fertilization and Embryology Authority, the American Fertility Society, all of them agree that there is no evidence to suggest that natural killer testing is helpful. Neither the Cochrane reviews either. But unfortunately, we have Googles nowadays. And it is not exaggeration to say well-established fact can be disputed if you Google them hard enough. So the media also plays an important part, and you have your fair share of the media, and you have your fair share of commissioned programs where people can say whatever they like without any peer review. We also have our fair share in the UK where people can make claims about improvised IVF and very cheap IVF, which is something really nothing short of manipulation. And also, every time we have a bit of a technological intervention, we tend to spread it like fire. And the last one is the time-lapse imaging. And because the machine is so expensive, it must be good. When you buy a machine of time-lapse imaging, it costs around 65,000 sterling pound. So you can imagine how expensive. What happens? The patient ends up paying for those expensive machines. And it is very sad, but in London in particular, you will find some clinics saying that treatment fees is X. But if you wanted me to put your embryos in the time-lapse imaging, it has to be X plus 500 pounds or 500, 600. Is this medicine? If we have a contract with the patient that we help them to achieve a pregnancy with whatever tools we are using, it is lamentable that we charge them by piece. If you wanted me to culture your embryos to day 5, you pay extra. If you wanted to have time-lapse, you pay extra. And I would have understood that if time-lapse has been proven to be of conclusive benefit. But sadly, it isn't. What we are left with is exaggeration. The patient enjoy, obviously, seeing the video of their embryos moving. But does this make them more likely to get pregnant? The answer is not. Some people claim that it increased the success rate by 50%. There is not a single randomized controlled trial to demonstrate this. And it is also important to remember that the imaging is fantastic, but the evidence is not. How about some other intervention where people talk about intralipid, which is made of soya oil, and you will find individual story. I had 5 or 6 failure, and then when I had intralipid, I had a pregnancy. Unfortunately, it does not prove anything. I have always cited a patient of mine where she had 3 unsuccessful attempts at IVF, and she was convinced of that immune therapy. We tell them, as I'm saying here, it's exactly what we tell the patient. Said, but at least give me something simple and cheap, like corticosteroid that might help. I don't usually give in to patient demand because either you are a professional or you are working in a supermarket, and there is nothing in between. But in this occasion, I felt that the patient is insisted and making a point. I said, fine, here is a prescription for prednisolone, 10 milligrams from the day of embryo transfer. 2 weeks later, the patient had a positive pregnancy test, and 2 weeks later, she came for her pregnancy scan. And while she was getting ready for the pregnancy scan, I was just making a joke saying, I can't believe that this pill has made the trick and given you the pregnancy. The patient paused and she said, doctor, I didn't tell you that on that day, the pharmacy was so busy, I went home without taking the pills. So the patient got pregnant without that intervention, and had she become pregnant, she would have definitely attributed it to corticosteroid. And there is plenty of that, where we put 2 and 2 together and we make 25. Also, there is the issue of aneuploidy screening and testing the embryos. Sadly, that has not promised has not delivered on what is promised. And those promises have been broken. The technique of aneuploidy screening had been practiced since late 90s. Only in 2007, it was demonstrated in a proper randomized controlled trial that is just not useful, but it could harm the chances of success. And sadly, despite this, some centers are still practicing pre-implantation genetic screening in the UK. And look at what is happening here. If you look at the red figure here, it is 16% live birth rate after PGS. That is a global figure. Luckily, it's not a huge number of cycles because people see sense. But what is 16%? If you give them just mineral water, probably they will do better. What people don't appreciate that the success rate is usually a battle between biology and technology. And when there is elasticity in biology, technology can help. But when the biology is forbidding, technology will not make any difference. I give you this slide, which relates to the live birth rate in different age group in the United States over 10 years period. You see the younger age group on top, where there is elasticity and they have good egg reserve. Over the years, the chances of success are going up. But when it comes to the older peers, look at the line. It is constant. So it is not technology, it is biology more than anything else. And we are very creative. We never stop without introducing something, and we market it. There is a new intervention. I'm not sure whether you've heard of it. It's called Ovasyns, which aims to transfer some mitochondria from the stem cells of the same patient's ovary into her eggs to rejuvenate them, to make them fresh, to make them young. It sounds too good to be true, and because of this, it is not particularly true. Sadly, this treatment is not licensed in the United States, but the company, which has been floated in the stock market 2 weeks ago, is practicing this in the Middle East and in different other countries. I am aware of a center in Dubai that is applying this practice. So it is important for us to be modest and to be humble and to acknowledge when we get it wrong that we have been misleading patients. We have been asking them to pay money that they are hard earning, and we need to acknowledge, just like this lovely dog, when he acknowledged that he was barking up the wrong tree. And those of you who have access to dollars, you will find a sign there saying, "In God we trust." For some of our colleagues, sadly, but I had to say they are a minority, not the majority, for them, in greed we trust. What controls people's mentality, probably greed or tama, more than medicine. Mr. Chairman, ladies and gentlemen, I think that is important, and that highlights exactly the dilemma that we are facing today from some of our colleagues. As long as greed is stronger than compassion, there will always be suffering. And those who suffer are our patients because we decide, or some of us decided, to serve their own interest rather than the interest of their patient. And I thank you for your attention.
Yeah, thank you very much for this really fantastic talk. We come to the next presentation, and we are starting with another topic with ovogynecology. And I'm very glad to introduce Dr. Yukada. He's consultant and the chairman of the Department of Orogynecology at the University of Hamburg. And he will present an interesting topic, the outcome of mesh-dependent therapy for genital prolapse and incontinence, different between postmenopausal and younger patients.
Good morning, everybody. First of all, I want to thank the Council for this kind invitation, for this great event you've arranged here, especially Professor Abu Nasr and Professor Ahmed Zakaria. Dear colleagues, I'm very happy to be talking to you about differences between the outcome of mesh-dependent surgery for pelvic organ prolapse and incontinence between late postmenopausal patients and the younger ones. And during my lecture, I will ask many times why. And the first why is why this topic? Because the prevalence of these entities, the stress urinary incontinence, pelvic organ prolapse, is very high. And the incidence in the literature ranges between 11 and 20%. And reports vary depending on inclusion criteria, source of information, size of the sample, and the geographic region. Maybe best of these data come from the USA, and this is very recent from 2014. This is in a survey a nationwide survey in the USA from the data between 2007 and 2011, and actually over 10 million patients were followed up to a maximum of about 25 million person years, so very big sample size, very accurate data, and they examined moreover than 60,000 first surgeries for stress urinary incontinence and a little bit less than 60,000 for first prolapse surgery. And what they found out was a distribution age-specific annual risk of these entities that shows a bimodal distribution. The first peak you see here is at about the age of 45. That means like 10 years after childbearing age, and it might be contributing to this peak. The second peak, one of interest for us today, is at the age of about 73, and this might be due to hormonal issues. And you see that a huge number of patients in the age between 65 and 75 are being scheduled in this study for surgery for pelvic organ prolapse and incontinence in that data we have here. This is about the cumulative risk, the lifetime risk for being scheduled for a primary surgery for stress urinary incontinence or pelvic organ prolapse, and you see that the cumulative risk increases steadily till the age of 80, at which this study had ended. What do the demographic data say? I'll look at the demographic data in Germany because I work there, and in the USA because they have always very big sample sizes. And in Germany, this is the distribution, age-related distribution in the society at the year 2000, and this is the prospective distribution in 2050. And I would like you to look at the groups aged 60 or 65 to 90, and you see that these groups are the increasing groups in women. So we have an aging society in Western countries, and the data from USA are rather similar. So in the year 2000, they had about 12.5% of the population aged 65 years or older, and it's projected that they will increase to 20% by the year 2030. And the group of adults aged 85 or older is the fastest growing part of this population. So we have the issue of a growing elder population and high prevalence for these entities, and we have very few literature about the outcome of surgery in these cases. What are the procedures we're talking about today? I said mesh-related procedures. So for the cases of stress urinary incontinence, we're talking about the suburethral slings, the TVT and the TVTO. And for the mesh-dependent pelvic organ prolapse procedures, we're talking about the sacropexy meshes and the vaginal meshes. Which age groups are we talking about? Patients in most of literature are divided into premenopausal, late and early postmenopausal, and the cutoff in the postmenopausal group can be at 65 years, 70 or 75. In most cases, the age of 70 was the cutoff, so was in our data, in our examination too. We're talking about outcome, but what is hidden behind the word outcome is very diverse. So there are measurable, objective outcomes, and there are patient-related outcomes. Actually, in most cases when we talk about pelvic organ prolapse, the success is meant to be the anatomical outcome, but there is still the functional outcome, so many patients may have a favorable anatomical outcome and still be rather unhappy because the functional outcome isn't sufficiently good, and we have to take in regard the complication, the perioperative morbidity. As for procedures for stress urinary incontinence, success means a good functional outcome. We don't talk about anatomical outcome in these cases, and we have the complications or the perioperative morbidity to talk about. I'll start with the group of stress urinary incontinence. So in this slide, you think you see nothing, but actually you see everything, because these are the data available about performing surgery in the elder population for stress urinary incontinence. There aren't much data around to talk about, and having a second look, Hellberg had reported of 113 patients, and it seemed that younger patients had a success rate of about 80% versus 55% the elder population. But this is a very small sample group. Another paper from Gordon examined 123 patients which are older than 70 years old, and it seemed that the outcome was as favorable as for the younger patients. You see very small sample size. Going ahead with that, we see from Aladdin 180 patients in all 3 age groups, and it seemed that the outcome was rather good in all groups and no statistical relevant differences. And Silvestre reported of 76 patients, and here the elder population had less favorable outcome than the younger. So very heterogeneous data we see here, and we got very few about long-term data. And here's one paper from the International Journal of Urology, and it's talking about 163 women who had been followed up for about 5 years, and we see that the cure rates were 66.7 in the elderly versus 80% in the younger, and that was statistically relevant. Not much data about the long-term outcomes. So, if you want to put this together, a review of the current literature will show that cure rates for stress urinary incontinence in older women range between 45 and 90% compared to like 73 to 95% in the younger cohort. So we see that the elder population may have a little bit less favorable outcome of this surgery. Still, the success rates are acceptable, and we have to offer that for our patients. What we must know about complications is that incontinence surgery of the elderly has a little bit high risk of complications, mainly having urinary tract infections and voiding dysfunctions. And these can be managed by longer antibiotic prophylaxis and intermittent self-catheterization. We have to keep in mind that with aging we have reduced detrusor contractibility and a slightly increase in post-operative voiding dysfunction, which might explain the data we have. Irritative urinary symptoms are often seen in elder patients, and those who suffer from that preoperatively, a lot of them have better outcome and less irritative symptoms after surgery. Also, not all of them are cured. Now I would like to talk about pelvic organ prolapse surgery. And here you see again not a lot of data we have to talk about. One issue that has been very present in Germany in the last few years was mortality. And you see heterogeneous information, mortality rate of 0%, mortality rate of 2.8 in 1,000 patients for those older than 80 years, and Friedman reported of a mortality rate of 0.8%. And going ahead with that, in most cases, no mortality was reported. So here again, very heterogeneous information. And the biggest group of patients analyzed was a survey from the USA. And in this survey, about 270,000 patients were evaluated, and it seemed that age-adjusted mortality per 1,000 women was low in those aged less than 60 years, was about 0.1 per 1,000, and was as high as almost 1 per 1,000 in the ages 70 to 80, and 2.8 per 1,000 in those older than 80 years. So in this survey, higher mortality rates for the elder population. What about the complications? The association between the complications and the age seemed positive also. So those aged over 80 years had 1.6-fold increase of complications after surgery. What are the confounders, the preoperative mortality factors which are associated with a higher risk for complications or mortality? the very ill patients, those suffering from severe liver diseases, have a fourfold increase of the mortality and morbidity. Those with renal problems or peripheral vascular disease has almost two-fold increase of these problems. So it's about how ill the patients are before we operate them. It's less about the kind of operation or the kind of procedure we perform. On the contrary to this survey, I will show recent data from the International Urogynecology Journal. This is from 2012, and this is a highly specialized tertiary center in the USA, and they report their own data of about 700 patients divided into these three age groups. And we see in the total number of intraoperative complications that only 3% in the younger patients and 2% in the postmenopausal and 1% in the late postmenopausal patients suffering from intraoperative complications. So here there's no statistical relevant difference between the group. Going ahead and looking at the postoperative complications in the same group, they seem to be rather similar, ranging from 29 to 32% of patients suffering from any kind of less severe or more severe complications between the groups. So in this case, no statistical relevance between the age groups. And that in this moment, I want to come to my next question, why? Why are the data from the survey so much different from the data of this tertiary center? One of the confounders we have to keep in mind is the volume treated by the hospital and the volume treated by the surgeon. And this is a very nice publication dealing with the impact of hospital and surgeon volume upon the outcome of reconstructive surgery, and they examined about 310,000 women in the United States in almost 3,000 hospitals, and these are the mixed data from the hospital. And what they did, they took the tertiary centers, the high volume hospitals as a reference, and looked at the data of those performing less procedures. And it's obvious that when we look at the outcome regarding the hospital, the medium-sized hospitals will have a 1.5-fold increase of death occasions compared with high-volume hospitals, and low-volume hospitals will have a 2.8-fold increase of deaths compared with the high-volume hospitals. And inside high-volume hospitals, we looked at the experience of the surgeons, and due to these data, we suggest that high-volume surgeons are even better with their outcome, so that medium volume surgeons have a 1.2 increase of complications, and low-volume surgeons 1.4 increase of complications compared to that. That's why we think that this special surgery of the elder population suffering from pelvic floor disorders have the best outcome in specialized centers, tertiary centers with high volume patients and high volume surgeries. These are our data collected between middle of 2012 till the end of 2014, and we had almost 500 surgical procedures. 260 of them were mesh-dependent procedures. The most one we performed was laparoscopic sacropexy, and our data show no conversion of surgical access. We had no conversion from laparoscopy to laparotomy, no blood transfusions, no bowel injuries, no injury of main vessels. We had hematomas that were treated. There were 4 out of the 206 patients. An observation in the ICU due to heart problems in 3 of those patients. The mortality rate was 0. These are the data, and I'm not going to go through it, but in the summary, they are